To finish up our discussion of lymphocyte neoplasms, we are shifting our focus to the last stage of B-cell maturation, the plasma cell. Just like in ALL and CLL, a mutation occurs in a mature B-cell. This time, however, this mutated cell further differentiates into plasma cell clones. Yeah, plasma cells. You know them. Those super specialized B cells that produce super specialized antibodies. And no sketchy discussion on B cells would be complete without a little antibody archery. Am I right? I know what you're thinking. Prithee, tell me from whence the plasma cells hail. First off, super strangely phrased question. And secondly, remember that B cells are born in the marrow. They then pop out into the circulation and head to the spleen, gain some IgD in addition to their IgM, and there you have it, mature B cells. They then circulate around, hit up a secondary lymphoid organ, like a lymph node, and wait for help from T cells. Now it's time to get activated. If a B cell latches onto a foreign antigen all by itself, then it turns into a kinda lame IgM-secreting plasma cell. With T cell help, on the other hand, it can become a super specialized plasma cell. You know, the ones with the cool antibodies like IgA, G, E. Most plasma cells head back to the marrow, their home base. And from there, they let their antibodies loose. In the plasma cell neoplasms, a mature B cell gains a mutation, resulting in clonal proliferation of plasma cells. And you know where they like to hang out, in the marrow. So check out the bone-shaped sign for the archery competition. It's filled with antibody archers, representing those antibody-secreting B cells. Not only that, we tried to convey the monoclonal nature of these plasma cell clones by making the pattern recurring, with each archer exactly the same. As we'll soon see, these clones secrete a monoclonal immunoglobulin that we can measure in the serum. This is called the M protein. Oop, here we go. Time to start the competition. Up first, Sir Milo, the most common plasma cell neoplasm, and one of the most common lymphoid malignancies in general, is multiple myeloma. This is a disease of the elderly, with a median age at diagnosis of 70. It also occurs more commonly in males and in people of African origin. In multiple myeloma, the clonal plasma cells infiltrate multiple sites throughout the skeletal system, hence Sir Milo's intimidating skeletal tunic. These clonal plasma cells synthesize large amounts of the same antibody, a monoclonal immunoglobulin, or M protein. M proteins are most commonly IgG, 60%, or IgA, 20 to 25%, but can be any type of immunoglobulin, including IgM, IgD, or IgE. On serum protein electrophoresis, or SPEP, which separates proteins by net charge, size, and shape, the monoclonal immunoglobulin produced by the neoplastic plasma cells will create a single narrow peak in the gamma globulin region, dubbed an M spike. M for monoclonal, not IgM. It's symbolized here by the peak on his M helmet. Recall that antibodies are normally composed of both heavy and light chains. Well, in addition to an M protein, which is a complete immunoglobulin antibody with both heavy and light chains, a bunch of extra free light chains are produced as well. Because free light chains are smaller in size, they're excreted in the urine, where they're termed Bence-Jones proteins. And in this scene, they're embodied by Sir Jones sitting on the bench, as usual. They only bring him in for special teams. See the tiny circlets that make up his chainmail? Those are light chains, and they're sitting above what I can only assume is urine. So how does multiple myeloma present clinically? Well, these plasma cells are invading the bone, remember? Therefore, one of the most prominent manifestations of multiple myeloma is lytic bone lesions, most commonly in the vertebral column. They can also occur in the ribs, skull, pelvis, femur, clavicle, and scapula. The entire life of an archery caddy, am I right? See the big, prominent hole in the spinal column-shaped quiver? Looks like he's gotten cracked in the head a few times as well. These lytic lesions weaken the bones they affect and can result in pathologic fractures. In the vertebra, pathologic compression fractures lead to back pain, which is typically induced by movement or change in position. There may also be a reduction in height. I mean, just look at that hunch. On X-ray, look for punched-out lesions in these bone areas. These lytic bone lesions are thought to be due to an imbalance between osteoclast and osteoblast activity. Osteoclast activity is increased, while osteoblast activity is decreased. At Sketchy, our recurring symbol for the bone-resorbing osteoclasts is a group of destructive osteoclastmates. As destructive as usual, it seems. Is he chewing on that? Anyways, while the exact mechanism of this is unclear, it seems that expression of RANKL, receptor-activated nuclear factor kappa B ligand, by osteoblasts is an important part of the process. RANKL binds to RANK on osteoclasts, increasing their bone resorption activity, Meanwhile, osteoblast function is suppressed, contributing to decreased bone formation. Increased bone resorption and decreased bone formation increases calcium levels in the blood. So look out for classic hypercalcemia symptoms such as kidney stones, bone pain, abdominal pain, depression, confusion, and lethargy. For more info on stones, bones, thrones, groans, and psychiatric overtones of hypercalcemia, check out the PTHD ice cream lab in the endocrine unit. Holy hand grenade! That was close. See the arrow retriever guy's ashen complexion? Multiple myeloma can also cause a normochromic, normocytic anemia due to bone marrow replacement by tumor cells. This leads to suppression of normal blood cell production. Remember, bone marrow infiltration was highlighted by those archers up on the bone sign. Expect the usual consequences of anemia: fatigue and pallor. In some cases, thrombocytopenia or leukopenia may occur for the same reasons: suppression of normal blood cell production. The risk of bacterial infections is increased too. Neoplastic cells inhibit the function of normal plasma cells, leading to decreased production of normal functional antibodies. Recurrent infections with Staph aureus, Strep pneumoniae, and E. coli are the most common. Oh shoot! It's Joan of Arc from our amyloidosis sketch. Our symbol for amyloidosis is an armored lady. And as usual, she's wearing her light chainmail, as well as a beta-pleated skirt, to remind you that proteins get all misfolded into a beta-pleated sheet conformation and accumulate in tissues. Multiple myeloma is associated with AL-type amyloid deposits specifically, which are composed of protein fragments derived from immunoglobulin light chains. Like in all types of amyloidosis, look for eosinophilic deposits on H&E stain, and apple green birefringence with Congo red stain when viewed under polarized light. Amyloid can deposit in the kidney, heart, tongue, and nervous system, wreaking havoc wherever it lands. Check out our immunopathology sketches for more info on amyloidosis. A final and important manifestation of multiple myeloma is kidney injury. Stay with me because there are a few reasons for this. Let's head back to the bench, because Bence-Jones proteins are the classic culprit. These light chains freely flow into the urine, where they bind uromodulin, previously called Tam-Horsfall protein, a protein that's normally present in the tubules. The combination of these proteins leads to the precipitation of dense cast that can obstruct the renal tubular lumen, resulting in acute kidney injury, or AKI. Hence the cracked kidney shield at the bench. Light chain accumulation can be toxic to proximal tubule cells, causing a generalized reabsorptive defect. This is called Fanconi syndrome, symbolized by the fan cone. When your proximal tubule isn't functioning, you end up excreting amino acids, glucose, phosphate, all kinds of stuff. You even pee out your bicarb, which causes a type 2 renal tubular acidosis. Amyloidosis can contribute to renal injury too, by doing her normal amyloid thing that she do, depositing as extracellular fibrils in tissue. Remember that hypercalcemia we mentioned? The excess calcium can deposit in the kidney too, causing injury, an example of metastatic calcification. In most patients, a bone marrow biopsy will show greater than 10% clonal plasma cells. The marrow involvement is patchy in multiple myeloma, so some patients require biopsies from several sites. See how the flag and target under the infiltrated bone marrow banner form the number 10? On histology, the bone marrow shows an increased number of neoplastic plasma cells. These often appear similar to normal plasma cells. An abundant rough ER fills the cytoplasm and stains basophilic. It needs lots of rough ER to make all those proteins. The Golgi apparatus doesn't stain and leaves a pale spot in the cytoplasm. And the eccentric nucleus has a wagon wheel or clock face distribution of chromatin. On peripheral blood smear, look out for rouleau formation. These are red blood cells that look like a stack of coins as a result of elevated serum protein levels. Or maybe like a stack of archery targets. Diagnosis of multiple myeloma involves a serum protein electrophoresis, or SPEP. Look for that M spike. Again, M for monoclonal, not IgM. Similarly, urine protein electrophoresis will detect Bence-Jones proteins. Treatment usually involves chemotherapy, and sometimes autologous hematopoietic stem cell transplantation. Since plasma cells are all about protein synthesis, they're particularly sensitive to proteasome inhibitors, such as bortezomib. Just think zamib for proteasome inhibitor. As you may recall from cellular biology, proteasomes are big protein complexes filled with proteases. They function like the cell's trash incinerator by degrading cellular proteins, including those that are defective and cytotoxic. The proteasome is represented by the always popular protein zone filled with butchers chopping up proteins. Inhibition of proteasomes causes accumulation of toxic and pro-apoptotic proteins within the cells, resulting in plasma cell apoptosis. Multiple myeloma is thought to arise from a premalignant condition known as monoclonal gammopathy of undetermined significance, or MGUS, represented by poor old insignificant Gus here. He'll just never attain the same caliber as Sir Milo.
Go home, Gus.
MGUS is characterized by a small spike of M protein without any of the symptoms of multiple myeloma, hence the undetermined significance. On bone marrow evaluation, there are less than 10% monoclonal plasma cells. So Gus's flag and target making a 10 shape are knocked down to the ground. Come on, Gus. Pathetic. MGUS is relatively common in elderly people, and when it happens, these patients need to be monitored closely because some will progress to multiple myeloma. Another lesion that carries a risk of progression to multiple myeloma is represented over here by this even less significant archer who somehow managed to get a solitary arrow stuck in his arm. Yep, not even sure how that happens. This depicts a solitary plasmacytoma. These lesions are plasma cell neoplasms that affect a single location. That location is most commonly in bone, where it causes pain or pathologic fractures. But there are no systemic symptoms. Bone marrow biopsy in the affected area shows proliferation of plasma cells, as expected. And treatment is primarily radiation therapy, although there is a risk of progression to multiple myeloma. Well, that's it for multiple myeloma, the biggie when it comes to plasma cell dyscrasias. Now let's meet our last competitor, depicting one more plasma cell neoplasm. Introducing Sir Waldenstrom, the embodiment of lymphoplasmacytic lymphoma, which can cause a condition called Waldenstrom macroglobulinemia. Whenever we talk about lymphoma, we bring in our chessboard symbol, which is meant to evoke an image of B-cell archers or T-cell knights abnormally congregating together. Now, lymphoplasmacytic lymphoma is kinda like a lymphoma version of CLL. In other words, it's hiding out in the marrow, and is comprised of neoplastic clonal mature B lymphocytes. Unlike CLL, however, you won't usually find neoplastic B cells in the blood, and many of these neoplastic B cells differentiate into plasma cells. These monoclonal plasma cells do what they do best, produce and secrete antibodies, of course. This time, instead of IgG, it's IgM. Hence his choice of projectile in this year's tournament, IgM Ninja Stars. On serum protein electrophoresis, the clonal bunch of IgMs result in an M spike in the gamma globulin region. Remember, this time the peak is caused by IgM, not IgG. In lymphoplasmacytic lymphoma, a bone marrow biopsy will show more than 10% infiltration. Again, represented by the flag and target forming a 10 shape. This time, it's not just plasma cells, though. Think lymphoplasmacytic, as in lymphoid cells and plasma cells. The other lymphoid cells include small lymphocytes and plasmacytoid lymphocytes. So let's draw in some other small lymphoid-looking targets next to the plasma cell target. IgM forms pentamers, a normal thing. But in the case of lymphoplasmacytic lymphoma, the massive volume of IgM pentamers is enough to significantly increase serum viscosity, resulting in a hyperviscosity syndrome termed Waldenstrom's macroglobulinemia. Just think of the hyperviscous mud that covers Sir Waldenstrom's lane. Unlike multiple myeloma, there's no amyloidosis, no lytic bone lesions, and renal insufficiency is rare. However, hyperviscosity causes a whole new set of problems. And they're represented here on Sir Waldenstrom's poor ninja star retriever, which, when you say out loud, sounds like the worst job ever. Sluggish blood flow to the central nervous system can cause headaches, dizziness, tinnitus, deafness, and confusion. Visual impairment can occur, reflecting dilated tortuous retinal veins seen on fundoscopic exam, a result of distension of the veins. In the peripheral nervous system, hyperviscous blood flow can lead to peripheral neuropathy, symbolized by our recurring stocking glove symbol, the usual distribution of a peripheral symmetric sensory neuropathy. There's also a tendency for bleeding, because the excessive amount of IgM interferes with clotting factors and platelet function. Additionally, precipitation of IgM pentamers at low temperatures can cause cryoglobulinemia, manifesting as Raynaud phenomenon, urticaria, purpura, and even tissue necrosis. Aside from causing hyperviscosity symptoms, the neoplastic cells can infiltrate the lymph nodes, liver, and spleen, leading to lymphadenopathy and hepatosplenomegaly, both of which are illustrated on the side of Sir Waldenstrom's trusty steed. Typical lymphoma stuff. Again, there's an invasion of bone marrow happening here, so expect anemia. The anemia can also be related to iron deficiency and anemia of chronic disease. Also, similar to what we saw with multiple myeloma, when you look at that peripheral blood smear, look out for significant rouleau formation. These are red blood cells that look like a stack of coins as a result of elevated serum protein levels. All right, how do we treat this thing? Well, severe pathologic hyperviscosity is a medical emergency. Plasmapheresis is performed urgently in order to remove the elevated levels of IgM from the bloodstream. You just filter them out. Treatment for the disease itself usually involves chemotherapy, though no drugs have proven to be curative. All right, let's sum up all the action from these antibody archer adversaries. We've got Sir Milo currently sitting in first place. Multiple myeloma is a plasma cell neoplasm of the elderly. Those plasma cells take over more than 10% of the bone marrow, potentially causing anemia. And lots of monoclonal IgGs are synthesized, creating an M spike on SPEP. In the urine, you can find light chains caused by Bence-Jones proteins. Clinically, look for back pain caused by osteolytic bone lesions and hypercalcemia. All those light chains can cause acute kidney injury or even amyloidosis. And currently, sitting at a close second place, Sir Waldenstrom. Lymphoplasmacytic lymphoma. Lymphoid cells, plasma cells. Sounds like I'm going to find both taking up more than 10% of the marrow. Lymphoma. Sounds like something that can take over the liver, spleen, and lymph nodes. Those plasma cells synthesize lots of monoclonal IgM, which creates an M spike on SPEP, and a hyperviscosity syndrome termed Waldenstrom's macroglobulinemia. Expect neurosymptoms, bleeding, and cryoglobulins. And that's it. Oh, yeah, almost forgot. There's Gus. But, yeah.